everybody is tired, but I will try to be fast and to the point. So, introduction, as we know, great effort for the management of end-stage heart failure, which is remaining a leading cause of morbidity and mortality. And we know in US, around 6 million patients with heart failure, and 10%, and means 60,000 patients with advanced heart failure need mechanical circulatory support or heart transplant. So with significant limited donor heart availability and many patients die while waiting for transplant, recent advances in the technology and outcome and surgical experience in LVAD make the LVAD is an alternative approach to heart transplant. And heart transplant, you need a tertiary care center, you need a lot of expertise, but LVAD can be done even in secondary hospital. So here, this is a picture of LVAD, where you can see the inflow cannula, the outflow cannula, and the pump, the drive line. So here, whom the patient candidate for LVAD. So young patient with advanced heart failure. Those with severe symptoms, dyspnea functional class 3 to 4, evidence of fluid retention, pulmonary edema, or systemic congestion like edema, ascites, evidence of severe cardiac dysfunction by echo, ejection fraction below 30%, mitral inflow restrictive pattern, deceleration time less than 150 millisecond, and in the right heart cath, you have pulmonary capillary wedge more than 16, right atrial pressure more than 12, and high BNP or pro-BNP. Severe impairment of functional capacity, like patient inability to do exercise. If you do 6-minute walk test, less than 300 meters, and we measure the VO2 max less than 12 ml per kg per minute. And if there is a history of heart failure hospitalization more than 2 per year, and presence of all this despite maximum medical treatment with beta blocker, with AC inhibitor, with diuretics, with angiotensin blocker. So the major indication for LVAD is bridge to transplant. Number 2, destination therapy. And now we have a patient up to 8 years after LVAD, and they have a good quality of life. Bridge to recovery, especially for young patient, and bridge for decision. So to select the patient, we use the Intermax, and we have Intermax 1, the patient who is present in a crash, they call it crash and burn. So there are persistent hypotension despite high inotrope intra-aortic balloon pump. And these patients require LVAD within hours. Sliding on inotrope, they are on inotropes, but their blood pressure is in the lower side. So despite maximum inotrope, so within days. Dependent stability. So they are on minimal inotrope within weeks to months. And patient with frequent flyer. They are frequently admitted to the hospital with heart failure. So these are Intermax 4. And here, housebound, they cannot do any activity because of severe heart failure. And if they walk, they are also with heart failure. So heart failure class 2, not currently indicated. So here I will show you some of the cases we did in our center. In our center, we did almost 14 cases of LVAD. This patient, he's a 36 years old male patient. He had maybe 4 to 5 hospitalization per year in different hospitals in the region. And if you can see the echo, his LV dilated, ejection fraction below 20%, a dilated left atrium, dilated right ventricle. If you see the 4 chamber, large left atrium, large right atrium, large LV, large RV, severely impaired systolic function. And he was on maximum treatment. He has mild tricuspid regurg and moderate mitral regurg. He has LV thrombus. Here you can see the VTI of the RVOT 8 centimeter, indicate very low cardiac output. Here the PA pressure around 40. See the mitral inflow, very restrictive. So this patient fulfill all the criteria of advanced heart failure despite medical therapy, and he is in Intermax 4 because of frequent hospitalization with heart failure. So here LVOT VTI is also low. This is the mitral regurg signal, and this is the speckle tracking strain rate. The S wave is reduced. This is the S wave, the yellow one, and this is the E wave, and we cannot say the A wave, and you can see sharp deceleration time indicate very high left ventricular end diastolic pressure. So this is, I'm trying to assess the right ventricular function, because right ventricular function is important. Some patient, you may do LVAD and the right ventricular function may crash and you end up doing BiVAD instead of LVAD. So this is, we can get the global ejection fraction of the right ventricle, and you can get the segmental ejection fraction of the right ventricle. So this is here again, you can see the strain. So this patient, and after discussion with the heart team, which include cardiologist, imaging, cardiac surgeon, perfusionist, psychiatrist, and nursing, so we decided to put him for LVAD, and he underwent LVAD successfully in our center. So here, everything went well. The patient, surgery may be finished at 5 o'clock. At 10 o'clock in the evening, the patient developed hypotension. So his blood pressure, mean blood pressure was 30 to 20. His heart rate, he was tachycardic. He was almost in shock. So the ICU team, they use all the tricks. So they give the patient fluid, no response. They increase the inotrope, no response. So here, transthoracic, difficult to see the image because usually difficult transthoracic. So I did the TEE middle of the night, and we see the, so try to find why this patient developed persistent hypotension. He was almost in shock. So here we got this one. So you can see there was turbulence in the LVAD inflow, and we put the continuous Doppler. It showed gradient more than 4, like severe aortic stenosis. So this is indicate obstruction of the LVAD inflow velocity. And another point here, very important, see the septal shift. We like always to see the interventricular septum in the center. If you see the interventricular septum shift to the right or shift to the left, there is a differential diagnosis. If it is shift to the to the left indicate suction or obstruction of the LVAD inflow. And here you have to reduce the speed. And this is what I asked the perfusionist to reduce the speed. Still here you can see a high velocity. This is after only reducing the speed. So this is HeartMate 2 when you reduce the speed. So the LVAD inflow velocity become normal. Normal less than 1.5 per second. And then you can see a laminar flow. Here, laminar flow. And patient did well. Okay, so this patient, we follow him for 1 year doing ejection fraction. I noticed in the first 3 months, the ejection fraction jumped from less than 15-20% to around 40-45. So I have a feeling in this patient, he recovered his LV function. So after 1 year of LVAD support, I did for him recovery test using transthoracic. We follow this patient every 2 weeks in the LVAD clinic and doing transthoracic, assess, see the size of the LV, reduction in the LV size, and improvement in the ejection fraction. And also the symptoms of the patient improve, hospitalization reduce, quality of life better, and ejection fraction around 45-50. So we did for them what we call recovery test. Recovery test, bring them to the echo lab, make the speed almost to, there is no speed, keep them for half an hour, and check if there is no symptoms of dyspnea, drop in the blood pressure, fainting, and the ejection fraction is stable, no drop in the ejection fraction, so we know in this patient, his LV function recover. Again, we repeat the right heart cath. If the right heart cath also normalize, we repeat another times echo. If everything is okay, and we decide to explant the LVAD, and we explant the LVAD for this patient after 1 year of support. And this is his, after explanting his LVAD, you can see the ejection fraction here, 46. And this is his transthoracic echo. There is mild aortic regurg. So the second patient is a young patient. She is 20 years old, female. She came, the first presentation, she came with cardiogenic shock. So came to the ER, arrested, intubated, and this is first echo. You can see LV dilated, ejection fraction may be 10%, global hypokinesia. And we kept her on maximum inotrope support, and we were not able to wean her from the inotrope or from the ventilator. So you can see mainly left ventricle, her RV is mildly dilated, it's MR moderate at least. So this patient, we took her in an emergency pace. Look at the mitral inflow, very restrictive. MR moderate, very low VTI, low cardiac output. See the red one is the S wave and the blue one is the E wave. Very reduced S wave and E wave. So this is the longitudinal strain, very low longitudinal strain. Normally longitudinal strain minus 18. This is very low. This is also strain rate, very reduced S wave and E wave. And this is the ejection fraction by speckle tracking, very low ejection fraction. And you look synchronized, so there is no desynchrony. Again, this patient, we put her for LVAD for 1 year, and her ejection fraction improved to 55 after 1 year of LVAD support. We follow her every 2 weeks with echo and checkup in the LVAD clinic. And this is her post LVAD. So after 1 year of LVAD support, we explanted LVAD. Her ejection fraction also came back to 50%. I did the recovery test, and we decided that this patient had LVAD as a bridge for recovery, and we explant her from the LVAD. Third case, again 45 years old male, severe heart failure, failure of medical therapy, ejection fraction below 20%, significant mitral regurg, severe MR. So again, dilated LA, RA, LV, severe mitral regurg. So you see ejection fraction here 14%, mitral inflow sharp deceleration time. Okay. So this patient in the night, he crashed in the night of the LVAD. He developed hypotension, and we did transthoracic echo. We found that there is some pericardial effusion and tamponade. So we have to take him back to the ORC, compressing of the RV and LV, RA, LA with large pericardial effusion. So he had, he went back to the OR and drained. And again, this patient, we follow him for 1 year, and we decide to explant the LVAD because he was a bridge for recovery. And this is his echo after explanting the LVAD. His LV becomes small, his ejection fraction improve. You can see mild MR. You can see the size of the left ventricular end diastolic. Before it was 7.1, now 4.9. Ejection fraction now 55, before 15 to 20%. So these cases are 3 young patients. We put LVAD as a bridge for recovery. This is case 4, again young patient with dilated cardiomyopathy, significant mitral regurg, very poor LV function, mild TR, good RV function this patient, significant MR. So this is 3D of the LVAD inflow cannula. So it has to be away from the septum toward the mitral leaflet. Okay, this is we do 3D assessment by LV quantification to assess the ejection fraction before in the OR before the LVAD and after the LVAD. So these cases I presented in the Europeans in the Heart Failure Congress in 2017, case 1, case 2. So in conclusion, improvement in clinical and surgical expertise in the LVAD has improved the quality of life in well-selected patients with advanced heart failure with a bridge to recovery. LVAD had shown a promising result of improved functional capacity, quality of life, and survival. Successful LVAD in advanced heart failure is crucial, dependent on proper patient selection. Thank you.